Hello all, this is Jess, and here is, I'm starting a series of recordings about rheumatoid arthritis, gout, and systemic lupus erythemia, which is otherwise known as lupus. So I'm going to share my screen, pull up PowerPoint. Now, yesterday in class, I mentioned that the first few slides of the PowerPoints are going to be case study questions to keep you thinking, get you thinking, help you process the information that's in the slideshow. So I'm going to actually skip the first 11 slides because they're case study questions. And let's start here. Okay. So we're going through, we're skipping some case study questions. Sorry if I'm going fast, look away from the screen. I'm clicking. So there we go. All right, so RA is a chronic systemic autoimmune disease. And what it is there's inflammation of the connective tissue in those synovial joints. And what is happening with that period of inflammation is, for whatever reason, the body's immunity system is like usually saving stranger danger for things that are outside forces, but for whatever reason, usually genetic, these people who have this condition are having the stranger danger inflammation reaction of their actual joints. So there are periods of remission and exacerbation. It does wax and wane. And then there can be some extra articular outside of the joints manifestations too. And it's disabling. It causes loss of independence. It causes loss of self-care. And there may be mobility aids or joint reconstruction if treatment, like with medications, is inadequate or ineffective. So it does affect all ethnic groups equally. The incident does increase with age. It peaks between the ages of 30 and 50. And it's estimated that 1.5 million Americans are affected by this. 3 times as many of those are women. And like I said, it's an autoimmune etiology. And it's a combination of genetics and then of environmental factors too. And there is a strong genetic predisposition to RA. However, smoking, just yet another reason to not pick up cancer sticks or vapes, increases the risk in patients genetically predisposed and may interfere with treatments as well. So here are some diagrams about rheumatoid arthritis in general. So in a healthy, let me grab a pen here. And let me change the color. There we go. So in a healthy, this is A is the healthy picture. So we have a nice thick synovium. We have some fibrin on the outside. You can see that there's a little bit of a cutout here of what a normal, nice synovium looks like. And then here, this blue part here, that's the cartilage, and then here's the bones. So if you look at B, what happens with people who have rheumatoid arthritis is this synovium, it stays the same, but the inflammation process starts to attack the cartilage within that joint. And so it really does create some havoc. And then as the disease progresses, we have increased inflammation in the synovium. We have very little cartilage. And so this, between the erosion of the bone edges, the destruction of the cartilage, there's loss of bone density as well. There's lots of swelling. And as you can see in this particular picture over here in D, it creates disfigurement in those joints. And then, of course, because of the loss of bone density, then the bones are actually that much more sensitive and easy to break. So variety of things happening with rheumatoid arthritis at that articular level. Articular means joints. So the onset is usually subtle. It doesn't like it's not like boom overnight. And where these people will start to actually see things before they get to joint deformity is they will have manifestations of anorexia, fatigue, weight loss. You may feel stiffness generally, but then eventually what it does is it becomes very localized. Sometimes, like I had said earlier, I mean, people who are genetic predisposition need some environmental stimuli to be able to start. And so people may report a history of a precipitating stressful event, such as infection. We can probably attribute some of the COVID-19 stuff maybe eventually down the road as a stressful event that could trigger somebody's RA genes to kick in. Stress, exertion, childbirth, surgery, emotional upset, but unfortunately, there's not any real direct correlation found in research when we actually do an investigative study on things. But there is some sort of loose correlation that's not statistically significant. Sorry to bring up, you know me, I'm always bringing in your old outside classes, and statistics is one of them. So there is specific joint involvement as things progress. And in these joints, there will be pain, stiffness, limited motion, and then signs of inflammation, like they'll be swollen, hot, painful. And then symptoms will often occur symmetrically. So if you have a problem in your big toe on the right foot, you'll have a problem in the big toe on your left foot. If you have a problem in your pointer finger on your right hand, you'll have a problem with the pointer finger on your left hand. And it often, the reason why I point out feet and hands is that it often affects the small joints more than it affects those large joints. The large joints can be involved, but usually when we have a larger joint or a C-spine problem, it's more often associated with osteoarthritis, that general losing of the cartilage, rather than RA, which is an autoimmune response causing the cartilage to go away. There will be joint stiffness after activity, morning stiffness, about 60 minutes to several hours or longer. Their fingers will end up being spindle-shaped. The joints will be tender, painful, warm to the touch, and that pain increases with motion, and the intensity can vary. Lastly, the manifestations that we'll see in our clients is tenosynovitis, which affects wrists. We'll have inflammation and fibrosis may cause deformity and disability. When we think of RA, we tend to jump to deformity, disability, but there's a lot of stuff that happens before that. Subluxation, is muscle atrophy, tendon destruction. So not only will the joints become inflamed and the patient lose bone density, but then those tendons that are helping the muscles move your fingers and toes and whatever else, the muscles atrophy, and then the tendons aren't there anyway. So people will lose use of their fingers or of their toes or of their feet or of their hands because of the RA, because of the muscle atrophy, because of the tendon destruction. People may have a walking disability. If you pop back to slide 15, those feet would be really hard to walk with. And then deformities in the hands. I'll pop to the next slide where you'll see ulnar drift, swan neck, and then boutonniere's deformity. So here are those particular deformities that were expressed in that last slide. This A is the ulnar disc, B is the swan neck, and then D is the boutonniere's deformity. And then C here is the ulnar drift as well, but it's not an ulnar drift, it would be a tibial drift because it's in the foot. And then here are some of those. There's a diagram explaining the extracurricular manifestations. These are really explored very well in your text, but RA does not just affect your hands and your feet. It affects a lot of different sorts of symptoms, and these people are going to be having lots of different related problems to their RA, not just that they, if untreated, will lose their, or could lose their hands or the use of their hands and feet. So when we're going through and working with these people the first time around, or when we're assessing them, we're going to be doing diagnostic studies. And so we'll be taking a history, we'll be noting physical findings. And then there is a nice table in the textbooks, table 64-6, but there'll be joint involvement. We'll be taking a history. We'll be doing some questioning about joint involvement. We'll be doing some blood studies, some serology. We'll be looking at acute phase reactants, and then we'll also be looking at how long those symptoms last. Remember, RA waxes and wanes. That's another difference between RA and osteoarthritis. RA will come and go. Osteoarthritis is just there all the time. So there are stages to RA, and the stages to RA include stage 1, 2, 3, and 4. So stage 1 will end up having synovitis. So we'll have that inflammation in the joints with soft tissue swelling on x-ray, possible some osteoporosis, but no real joint destruction. So these people will complain of like achiness and stiffness because of the inflammation in their joints, but they're not going to have necessarily that joint destruction phase that's coming. Stage 2 is increased joint inflammation, and that's stage 2 is where that joint cartilage starts to be destroyed, and then you'll actually see they'll actually see a narrowing in the joint space from loss of that cartilage. Stage 3 is extensive cartilage loss. There'll be erosion at those joint margins, and this is where possible deformity starts. And then stage 4 is where they'll lose joint function. They will have joint deformity. Inflammatory process actually subsides because there's nothing really left to attack with the immune system. And then there may be formation of subcutaneous nodules. But for the most part, stage 4 is, and the thing is we can get people, if we can get people in stage 1, hopefully we can keep them managed so they won't get to stage 4. There's no going back. So if we're at stage 1 and then we progress to stage 2, we can't get them back to stage 1 again. So that's why it's so important for these people to be able to have a program that they can adhere to, so that they can avoid, or we can do our best to help them avoid progression of the disease. As far as lab tests, that serology that I mentioned, there's CBCs, ESRs and CRPs are active when you have inflammation. There is this RF, this rheumatoid factor, is positive in about 80% of adults that have rheumatoid arthritis. So we're not going to go on RF alone because we will miss 20%. And then there's some antibodies and some autoimmune reaction studies, as well as those bone scans, X-rays, and then we can also take a draw off the synovial fluid in those affected joints and take a look at it. So normally the synovial fluid in a person without this disease process going on is clear and might be just a little bit, it's not as thin as water, but it's definitely not cloudy, and it's definitely not straw colored. And then they'll also have fibrin flex, and then they can find what this MMP3 agent in there as well. So I'm going to stop recording here, and then I will record chapter 2, which will be interprofessional care. Hello, this is Jess again. We're going to be looking at chapter 2 of rheumatoid arthritis, which is interprofessional care. I'm going to share my screen so that you can see what I'm talking about while I'm talking about it. Let me advance the slide here. So interprofessional care, it will be an individualized treatment plan because this is going to be manifesting itself a little bit differently in everybody, just as people's autoimmune processes manifest just as unique as their fingerprints. So we're going to be designing an individualized treatment plan to help maximize things and keep them in the stage that they're in. Like I had said in the previous slide, we can't go back in stages. So we want to keep them in the stage that they're in, and hopefully work with them in an individualized treatment program so they're not progressing into further stages. We're going to be looking, to be able to do that, we'll look at disease activity. We'll look at the joint function that they currently have. We also kind of look at age, sex, family and social roles, and response to previous treatments. Aggressive early treatment will keep their prognosis better and hopefully prevent their progression into a further stage of rheumatoid arthritis. Remember, there's 4. So drugs are the cornerstone of treatment. Irreversible changes can occur even within the first year. So what will happen is HCPs will prescribe one of 2 different classifications. They will start with disease-modifying anti-rheumatic drugs because they slow the progression and decrease joint deformity and erosion. The drug chosen is based on disease activity, functional level, lifestyle considerations, because some of them are only available IV. We'll get there. And then the second classification of drugs that people will be prescribed are biologic response modifiers. They can also be called immunotherapy. They do help slow the progression. They are classified on the basis of their mechanism of action. And people can be on a DMARD and no BRM, or they can be on both. Very rarely are they on BRMs solely, but we'll get there. So when we're talking about DMARDs, methotrexate is the most common first-line medication. It works really good if we can get it early on in the disease process. It has a lower toxicity level. The side effects are very rare. The people on methotrexate may have bone marrow suppression, and then the liver processes this. They may have some hepatotoxicity. But we will be monitoring their CBC and their blood chemistry as well, because this can also impact kidney function as well. So this particular drug can do a double whammy, but like I said, the side effects are rare. We need to make sure that people are drinking water and keeping well hydrated when they're on methotrexate, so that we don't have a concentrated methotrexate level in the blood banging on the kidneys and making them sick. Therapeutic effects in 4 to 6 weeks. This is not as simple as taking an aspirin. This is not as simple as taking a painkiller. So they may be, and then methotrexate may be given alone or within biologic with biologic response modifiers. Other DMARDs that you may see are sulfasalazine, hydroxychloroquine. By the way, this is the labeled use for hydroxychloroquine, not other things that people have been talking about the past year. So we use this for mild to moderate disease. So if somebody is kind of in that stage 1 progressing to 2, stage 2, late stage 2, maybe to 3, we'll be using these particular drugs. We need to make sure that they're drinking fluids. And we also, these people become very photosensitive, and they can burn very easily in the sun. So people who are on these 2 particular drugs will be wearing sunscreen like all the time. SPF 100 is a good deal. We will also be doing an eye exam baseline and then every 6 to 12 months, partly because of the sun's effect on the retinas, and partly just to make sure that their retinas are able to handle this particular level of treatment. Excuse me. Let's see here. So then we also have the flunomide, which will be blocking immune cell overproduction, but this is a teratogen. And remember, people who are ages 30 to 50 and female, 30 to 50 is when it usually starts presenting itself, 3 times more females than males. We need to make sure that these people aren't planning or thinking about becoming pregnant and starting a family that way, because the teratogenic drugs are not healthy for babies, developing fetuses. As a matter of fact, they're anti-developing fetus. So the other thing, and I hear a fair amount of commercials about Xeljanz. Xeljanz is a specific enzyme inhibitor, the Janus kinase inhibitor, and that enzyme causes joint inflammation. But it's really only used for moderate to severe active disease. This particular one, this particular Xeljanz, you cannot be using live vaccines. So we need to make sure that when we're administering the normal flu vaccine or COVID-19 vaccines or any sort of vaccines, that they're not getting live vaccines. They have to be able to get the unlive vaccines. The word escapes me, sorry. Next is those biological response modifiers. So they do slow the progression. They are based on the mechanism of action, and they're used to treat moderate to severe disease that's not responsive to DMARDs. They can be used alone. They can be used in combination with DRNA or DMARDs. So you may have somebody that's on a BRM and methotrexate or Xeljanz, or you may just have somebody that's on a biological response modifier. So tumor necrosis factor TNF is the basis for a lot of these medications. But one thing I wanted to point out here is a lot of these are injections. So Enbrel is a subcutaneous injection. Infliximab or Remicade is an IV infusion. Adalimumab, Humira is a subcutaneous injection. So when we are working with these people, we not only have to work with them about how to monitor infection, how to avoid live vaccinations, and then what to report, bruising, bleeding, persistent fever, or other signs of infection. We're also going to need to either, as their case managers, make sure that they can get into the infusion lab, or we're going to have to be teaching how to administer a subcutaneous injection. So there's definitely some patient education that is involved with biological response modifiers. And some of these on this particular page are given IV. So they're in the infusion clinic, or they also need to have a sub-Q education as part of their discharge education as well. Adjuvant drug therapy. This is, sometimes people will have adjuvant drug therapy along with it. Like, how do we help them? Because, like, remember when I was talking about methotrexate and how it takes 4 to 6 weeks to be able to really kind of go in and have full effect. What do we do for people who are having flares, right? Or in that 4 to 6 weeks while we're waiting for the methotrexate to really kind of kick in, we can do corticosteroid therapy, just like we had talked about when we were talking about back pain like a month ago. We can do low dose oral meds for a limited amount of time. Or we can actually do those articular injections. So we can actually take little needles and like inject them into the synovial areas. But there are complications with corticosteroids such as osteoporosis. Remember, one of the effects of rheumatoid arthritis is bone density problems. So you put RA, bone density problems, on top of osteoporosis caused by corticosteroids. You can also, bad deal. And then there's also avascular necrosis. So necrosis is dead tissue. So dead tissue not involving the vessels, avascular necrosis. NSAIDs and salicylates, aspirin, NSAIDs, may be used to treat the pain and the inflammation. There are some long-term ones, like a COX-2 inhibitor. Those can take up to 2 to 3 weeks for full effectiveness. Non-aspirin NSAIDs do increase the risk for blood clots, heart attack, and stroke. So there are some definite education points that we need to bring along with us when we're having people on NSAIDs and salicylates. The one thing that we need to really make sure that these people know is these medications build up and work over time. This is not something, there is no, I wish there really was, like a magic wand. And so people can get really psychosocially distressed, not only about like the fear of disfiguration and the loss of mobility and the loss of ability to do ADLs, but also while they're waiting for their treatment regimen to actually kick in. So that can really impact adherence, because if they're getting frustrated with their treatment or with their medications not taking enough time and then we have to try and figure out what is exactly going to work for them, it can be a super frustrating time. So we'll need to be aware of that when we're designing their education and doing a lot of listening. We can also bring in other members of the interdisciplinary team, not just primary care providers and meds. So we're going to be working with them on balanced nutrition. These people are tired and they hurt and they have depression because they're tired and they hurt, plus they're going through a big deal. Those can lead to decreased appetite, but we need to keep their intake on the healthy side, right? So that they can work through this as best they can. A person also can have lower endurance and mobility, and then that can cause an inability to shop and prepare for food, and that can prepare their food, resulting in weight loss as well. So working with occupational therapy, not just to the nutritionist to be able to make things balanced, but occupational therapy is going to be a huge part of this as well, because if they can't manipulate tools in the kitchen, how are we going to have them eat healthy stuff? And then the people who are on corticosteroid therapy may have weight gain part of their steroids. So that is an unintended or an unhealthy side effect of steroid therapy. Excuse me, thanks for indulging me there. Is that weight gain from the corticosteroids. So again, we need to make sure that we have a balanced nutrition plan to be able to help them avoid weight gain from their steroid therapy. And then lastly, we may be resulting in surgical therapy to relieve severe pain. It can improve function. So there's two different kinds. We can do a synovectomy, which is where we're actually just doing that. It's a little bit less invasive, and we're really just taking out the synovium, synovectomy. Or a person could have a total joint replacement. My friend Natalie had both of her knees done at the same time. Brave woman. She had two knees done at the same time. She had total joint arthroplasty. So total knees, if they're in the shoulders, total hips. We're at nursing management. So again, I'm going to stop sharing here and I'm going to start a new chapter. So I will see you back here, hopefully within a few moments, and I'll start talking about how we as nurses help manage this process with our clients. Alrighty, so chapter 3 of rheumatoid arthritis. I've got a hitch in my throat, I apologize. All right, I'm going to share my screen so we could get into nursing management of rheumatoid arthritis. Here we go. So we're going to be gathering subjective data, that patient-reported data, past health history, medications, any other surgeries or treatments, any joint surgery is all very important to our subjective assessment, as well as functional health patterns. So how do they perceive their health? What do they have in their family history? Are they tired? Do they have general malaise where they're just kind of like, I have barely enough energy to get through the day. Actually, I don't have enough energy to get through the day. I'm surviving on pure spunk. And are they able to participate fully in their therapy regimen? How has their functional ability been impacted? We'll take a look at their nutrition, like I was talking about in interprofessional care. They may have anorexia or weight loss. They may have dry mucous membranes of the mouth because of their medications. Fluids are important. Their oral pharynx in general may be dried out. The other thing is if they're using a lot of corticosteroids, we may also want to look at their nutritional metabolic needs in terms of the corticosteroids affecting their weight gain. We'll look at activity. How is their stiffness doing? How is their joint swelling doing? Do they have muscle weakness? Are they having problems walking? Are they just tired? Cognitive, perceptual, they may have paresthesia, that pins and needles of their hands and feet. They may lose sensation of their hands and feet. They may usually, remember, RA happens simultaneously on one side or the other. It's bilateral, one side and the other. It's bilaterally equal. So symmetrical joint pain. And then does that increase with motion or stress on those joints? Objectively, what we can look at, see, observe, we can look at their lymph nodes and see if they have swollen lymph nodes, lymphatic, that word. Sorry. My oral pharynx is not adjusting very well this morning. Do they have a fever? How's their integument? Do they have any scleritis, any inflaming in their eyes? Do they have any of those subcutaneous nodules that are present in stage 4? Skin ulcers. Do they have shiny, taut skin over their joints because they're just so inflamed that the skin is just pulled really, really tight? Any edema in the periphery? We'll take a look at their CV. They may have Raynaud's phenomenon, distance, heart sounds, murmurs, and dysrhythmias. Raynaud's phenomenon is where when their hands get cold or their feet get cold, they go white. When we're coming in from the outside, unless we have frostbite, our hands are pink or red when they're cold. When they're really cold, they get really red, right? When a person who has Raynaud's happening, a Raynaud's phenomenon is where they're, when they're cold, the very tippy-tippies of their hands and toes are white. Respiratory-wise, they could have bronchiectasis, they can have pleural effusions. We want to check for tuberculosis with these patients because we have them on anti-immunosuppressant therapy. So TB, we're constantly taking a look to make sure that they haven't been exposed, because if they get exposed to TB, they don't have a whole lot of reserves to fight that off, as well as interstitial lung disease. We also will be doing, we'll be taking keeping an eye on their spleen. Splenomegaly is common as a manifestation that can happen with people who have rheumatoid arthritis. It's also known as Felty syndrome, but in a large spleen, splenomegaly. Objective data continuing, they can have musculoskeletal problems. This is where we really expect to see their problems, right? Because it's rheumatoid arthritis and it's affecting those joints. So symmetric joint involvement, if they have problems in one pointer finger, they will have problems in the other one as well. Swelling, erythema, that's redness, heat, tenderness. They may have deformities. They may have joint enlargement. They may have limitation of movement, muscle contractures, muscle atrophy. As things progress, this list, the way they have this list is it's all from stage 1 to stage 4. So just because if they have muscle contractures and muscle atrophies, they are not in stage 1 RA. So just so that you're aware, this is an all-encompassing list of all 4 stages. Possible diagnostic findings in terms of labs and x-rays, we can find positive rheumatoid factor, ANA, anti-CCP, elevated erythrocyte sedimentation rates, anemia. Remember, a lot of those drugs that they're on create bone marrow suppression, so we may find that they're anemic because they're not making their hemoglobin, they're not making their RBCs. We may, if we do a synovial joint fluid extraction, we may find elevated white blood cells in that synovial fluid, and then that x-ray will have evidence of joint changes. when we are working with these people, we have both physical and psychosocial emotional nursing diagnoses. The easy peasy ones: impaired mobility, chronic pain, and disturbed body image. Overall goals for our clients with RA, they need to be satisfied with their pain management. If they're not satisfied with their pain management, it's going to change their adherence. Like, why am I even doing this? I'm spending hundreds of dollars on medications every month and I'm not getting any benefit. We want to minimize their loss of functional ability. We want to make sure that they're participating in their therapeutic regimen, and that their therapeutic regimen is something that they can actually participate in. We're working with them to maintain a positive self-image as much as we can, and we're helping them complete their and perform self-care. When people stop or lose the abilities to care for themselves, it's a huge psychosocial impact, and it causes a lot of problems when you can't perform self-care. So unfortunately, prevention is not possible. This is not one of those things where we can not smoking for somebody who has RA going out throughout their family, but it hasn't manifested itself yet. It's probably a good idea, but overall prevention really isn't possible. However, the sooner we get on top of it and the sooner we start treating, the better outcomes and the more prevention of further joint damage happen. We can set up community education groups for symptom recognition to promote early diagnosis and treatment. The Arthritis Foundation is a wonderful resource for people. They put together support groups. They put together all sorts of different things for patients to help them be better, more successful. Sometimes they're thinking about things a little bit differently than maybe what we can think about them, and they're able to we're able to partner with them for some better outcomes. And acute care, if those are people who want to go into bedside nursing, may not see these people very often. Most of the care for people with RA is done on the outpatient level. So they may be hospitalized for some sort of systemic complications or for surgery. More often than not, if we see them in the hospital, it's pre and post operatively for surgery, either in the outpatient setting or in the inpatient setting. We'll be working with, therefore, these people require a lot of interdisciplinary teamwork. We work a lot with the healthcare provider, PTOT, and social work to be able to have these people get the best possible outcomes that they can. Ambulatory care is where where nursing sees and where these people spend a great deal of their treatment time. So the drug therapy that we had talked about in interdisciplinary care, as well as non-drug therapy. So this is where we end up doing a lot of education about clustering cares and clustering activities. How do we balance rest and activity needs? These people get very fatigued very easily. So how are we going to help them be able to maximize the energy that they have and then rest up to get that max energy again for some more stuff? Heat and cold application. When you have chronic pain, a lot of people respond well to heat. I know that when my friend Luella was married to a gentleman and he had RA in his hands. And so even though they had a perfectly functional dishwasher, he washed the dishes after every meal, because especially after breakfast, because when he woke up, his hands are really stiff and tired and cranky. And so that act of washing the dishes in warm water and then rinsing them in the tub of warm water as well, and then putting them into the dish rack, did a few things. First of all, the warm water helped with his joints. Secondly, the activity helped him with his occupational therapy needs and keeping that mobility in his hands. Thirdly, he was able to complete some of the activities of daily living that are associated with their keeping up their home. And so he was able to keep his sense of self by doing something simple as washing the dishes. We also can help them with relaxation techniques, joint protection. There's some tables in the book about that. How do we protect those joints? How to support them? Biofeedback is a cognitive feedback sort of therapy thing where you are doing mental body scans and taking stock of yourself internally, and then you're working through different problems. I have a picture here of a TENS unit. TENS units are electrical muscle stimulators that these little pads go on outside of the body, give very little gentle, varying degrees. You can set the intensity degrees or the intensity on there. And then they give gentle sort of pulsations of electricity to help ease muscle tension. Hypnosis also helps for pain management and for psychosocial problems as well. So we're going to be helping them learn how to alternate rest periods and activity periods, and what helps relieve their pain and their fatigue. The amount of rest will vary between people, and we don't want them to lay in bed all day. That total bed rest is not healthy because it doesn't let you're not working your muscles, and we need to work the muscles. So 8 to 10 hours of sleep plus daytime rest. And it can just be like a simple downtime thing. Does not have to be like laying down and taking a nap, but perhaps they have a favorite television. Maybe they're just gonna watch Drew Carey on The Price is Right at 10 in the morning. And then, they'll do activities of daily living up until 10. They'll take some time. They'll watch The Price is Right, come on down. And then they'll go on with some more activities. And then maybe there's another television show that they can relax and watch, or some other like reading. Maybe they have scheduled reading time in the afternoon, and then they can do some more activities of daily living. And they kind of have this sort of like rest activity cycle. And there are times where we can modify activities to avoid exertion. Like I said, Luella's husband did not wash all of the dishes in one swoop. He washed them after every meal. You can also do, there's all sorts of different ways that we can partner with occupational therapy, make activities easier and help avoid overexertion by having some simple, like a shower chair to be able to help out with showering, etc. We'll want them to have a firm mattress or a bed board of some sort to help them be able to get out of bed. Softer mattresses kind of like sink it. Don't get me wrong, they're sometimes really comfortable, but they're hard to get out of, even for people who are able-bodied. We're going to be encouraging positions of extension and avoiding flexion positions. No pillows under the knees. We can start seeing contractures in the hips and in the knees when there's pillows under the knees. And then a small flat pillow under the head and shoulders to be able to help with contractures in the neck. Sorry, just talking about that made me want to roll my neck. Okay. Then we're also going to be doing some modification of tasks to create less joint stress, energy conservation. How do we pace ourselves? How do we organize our activities? The use of carts and wheelie suitcases and all sorts of things. If we can have gravity help us out, let's have gravity help us out. And delegation, or delegation is different than asking for help. Asking for help kind of gives the person an option. Delegation is, I need you to do this. So giving them the empowerment to delegate things when they're unable to do them. And then, like I said on the last slide, we're going to be working with occupational therapy on assistive devices to be able to help make their lives easier as well. We'll be using cold and heat. Cold is especially beneficial during periods of flare of disease activity, but we need to limit it to 10 to 15 minutes at a time. Bags of frozen vegetables work really good, just like all of our athletes use. I have a designated bag of mixed vegetables that we will never ever eat because we use it as an ice pack. So those bags of frozen vegetables actually last longer than ice, which is nice, but no more than 10 to 15 minutes at one time. And then moist heat, like I said, Luella's husband washes the dishes. It helps relieve chronic stiffness, but it shouldn't exceed more than 20 minutes at a time. Also why he washes them one meal at a time. Heating pads, moist hot packs, paraffin baths are those when you're dipping either your hands or your feet into warm wax. It's sometimes used at the spa as like a special spa treatment. Warm baths, showers. We should avoid using those topical heat producing creams like icy hot. And then they need to be alert for the burn potential because the skin is especially pulled tight across those joints. It's that much easier to develop injury. And so we need to have them be really alert for burn potential when they're using heat. Individual exercise plans, encouraging program performance to reinforce correct performance, and the need for both recreational and therapeutic exercise. This person should not be going and joining the football team through the rec league. They should be avoiding aggressive exercise, but going out and enjoying nature or finding them some sorts of exercise that can be perhaps recreational and therapeutic at the same time is a win-win. Gentle range of motion exercises should be done daily to keep those joints working. Aquatic exercises in warm water are totally beneficial. So if they can find a warm pool, not a cold pool. I used to do aqua aerobics in a 65-degree pool and it was torture. But in a warm pool, and then limiting to 1 or 2 reps during their periods of acute inflammation. They can easily overdo it when they're in a flare. So during acute inflammation, 1 or 2 reps is more than enough. We're also going to be working with caregivers through this too. So a thorough program of education and drug therapy is needed about the disease process, about home management, about drugs, administration, timing, side effects, lab monitoring. Effective self-management adherence requires an understanding of the disease process itself, the nature and the course of disease, and the goals of therapy. We also need to make sure that their plan considers their value system and their perception of the disease. When we're looking at this particular disease process, it has a lot of psychological impact. So that value system and their perception of it really impact their lives. Patient challenges. They're losing function. They're tired. Because they're tired and they're losing function, they're losing self-esteem because they're not always 100% able to do what it is that they normally did. Body image alterations are definitely possible. Fear of disability and or deformity is definitely possible, as well as alterations in sexuality. When we have loss of self-esteem and altered body image, that can definitely alter our sexuality. They may decide to investigate unproven or even dangerous remedies. The snake oil salesman type of remedies can be very, very tempting to be able to try and get that sense of self-esteem, get that function, get that fatigue back, or dismiss that fatigue. And then we need to work with them to recognize their fears and concerns, evaluating of their family support system. This particular people might need to have some different changes in their finances. Maybe they can't continue in the work that they've been doing. We are going to be considering community resources with them. There are self-help groups that are helpful for some patients not so much. Depends upon who they are. And then strategies to help decrease or work with the depression that can be easily associated and accompanying a diagnosis of rheumatoid arthritis. As people age, there are some different gerontologic considerations. There is an increased prevalence with older adults. Specific areas of concern, they may also have osteoarthritis. So double whammy, osteoarthritis, your joints are wearing out, your cartilage is wearing out because you've been using them. And then rheumatoid arthritis on top of it. Let's just throw an inflammatory process on top of it. Interpretations of lab values are more difficult. And as we age, we get, there are times where it's just harder to learn new things. It's not impossible to learn them, but interpretations of lab values can be more difficult. We need to recognize the fact that these people who are in that gerontologic category often have polypharmacy. They often have muscle pain and weakness related to depression and inactivity. And other diseases may develop in milder forms. Congratulations, you get another autoimmune problem on top of this, like lupus. We need to make sure that our older adults may also be sensitive to therapeutic and toxic drug effects. Their liver doesn't work as well, their kidneys don't work as well, so then it's easier for drugs to build up in the system. Polypharmacy can create increased interactions, and when you have more than one drug, it's easier to have toxic levels when your liver and your kidneys are just overwhelmed by processing all of the stuff. Osteopenia, that bone loss with corticosteroids, may increase the risk of pathological fractures, and then a support system, which can be really hard for our people who have been independent for a really long time and take a lot of pride in the fact that they are able to do things on their own. They've been, living on their own for 20, 30, 40, 50, 60 years, and now they need to ask for help. And it can be a real psychological twist for them to now need help. Here's an audience response question. I'll give you a moment to think about this. And here's our answer. That concludes rheumatoid arthritis. I'm going to stop sharing again. And I will be continuing on this morning with some more lectures, but feel free to take a break after rheumatoid arthritis. Complete those case study questions if you weren't doing them as I was talking, to help you process the information. And I will see you for gout and for SLE, depending upon where it is that you take this series of YouTubes. So have a great day.